Hi, I'm Chris Garvey. I'm a nurse practitioner at University of California, San Francisco. My coworker, Julia Rigler, and I are going to be talking to you today about remote pulmonary rehabilitation. We have no specific disclosures related to this topic. I just want to mention this is dedicated to the memory of John Murray, who advanced the science and care for all with lung disease. Julie and I want to thank AACVPR, American Thoracic Society, and all the clinicians who work tirelessly to keep our patients safe and healthy. It's an honor to be talking to you today about this important topic. And we don't endorse the models that we're talking about today. These are offered more as a resource to you to consider and decide what is the best approach for you and your program and your patients. So all of us are living in a different world. Sometimes I feel like I'm living in a science fiction movie. So I think it's worth just commenting on shelter in place. This is a study that the UCSF Division of Infectious Disease, along with the San Francisco VA and Zuckerberg San Francisco General Hospital, looked at, where they compared two regions in northern Italy. And Lodi, which is in orange, was a region where they used strict adherence to shelter in place versus Bergamo, which had some delays in that approach. And I think once we get to the other side of this difficult time, none of us will regret being too careful about our approach. So that leads us to why we might consider remote pulmonary rehabilitation. It didn't take Julia or our medical director or I very long to figure out we needed to come up with a different model. So on March 17th, we went to 100% video for pulmonary rehabilitation and also our sleep and pulmonary practice. So why not? Well, in the United States, remote pulmonary rehabilitation is not paid for yet, although AACVPR is working very hard to try to achieve that. So it is being worked on very carefully and in a very focused manner. So I think there's some important considerations for remote pulmonary rehabilitation. I think now that this is all sort of sinking into us, that we are living in a very different world and we're not going back to our previous lives anytime very soon, that we recognize, and I think our patients are also recognizing, that linkage with the clinical team can be very beneficial and potentially have benefits. So we'll talk about those in a minute. Also, I don't think we're the only ones that have changed our approach and really have a very different job now than we did, say, before March 17th. So many programs are not offering center-based pulmonary rehabilitation, and to transition back to that, which we know is an effective model, this may offer an easier restart once it's considered safe. So pulmonary rehabilitation in the home setting has been used in Europe, Canada, and Australia. And I think Canada and Australia have extensive experience with it. So there may be opportunities for developing models in the US and studying them and improving them and recognizing that they may have a role after our life returns to a little bit more of a normal type, and particularly for patients that can't access center-based pulmonary rehabilitation. I think that's what's driven Australia and Canada to consider very seriously. The study at the bottom of this slide is a study from Francois Maltais and Jean Bourbeau in Ontario. It's a randomized controlled large trial, actually from 2008, so to give you an idea of how long they've been at this. And this looked at comparing home pulmonary rehabilitation to center-based pulmonary rehabilitation in severe COPD patients. And they had similar outcomes, and at the end of 6 months, similar findings. So it is becoming more established and more understood. So where are we? A group of ATS clinicians interested in pulmonary rehabilitation has been talking about this since it started to become a topic earlier this year. And we're rather clear that for remote pulmonary rehabilitation to be effective, We don't know that it is for in the US. It's been evaluated in other countries. But to deliver improvements in outcomes, it needs to include all of the essential components of pulmonary rehabilitation, including exercise training, education, and behavior change. So we'll talk about that in a minute. Now, Anne Holland and Surya Bhatt are probably two of the more established experts in this field. Anne Holland out of Australia has looked at phone-based structure calls by health professionals trained in motivational interviewing. And at the bottom of this slide, you can see a nicely designed study that she published on this topic. Surya Bhatt is a pulmonologist out of University of Alabama, and I consider him one of the most established researchers and clinicians in the United States in this area of interest. And he's worked with other pulmonary rehabilitation experts at his setting to look at video telehealth pulmonary rehabilitation in COPD patients, and has found that it has a favorable impact on reducing 30-day readmissions. So where do we start? Just like center-based pulmonary rehabilitation, assessment is really the key. Getting an accurate diagnosis, and this could be based on, or should be based at minimum, on a pulmonary function test, and may include a chest CT and other testing, comorbidities that can very much influence a patient's safety and ability to adapt to a home model of exercise, what medications and therapies they're using. How is their dyspnea at this point with rest and exercise? We use a board category response scale that you can see here. As in center-based rehab, hypoxemia is a critical area to evaluate. We're looking at requiring all patients that have remote pulmonary rehabilitation have an oximeter. The last time I looked, they're still quite available on Amazon, and they need to be trained how to use them properly. ATS and other organizations have some good resources to support this. So what are their oxygen needs? What are they actually using? Some parameters, and what are their systems at home? We are moving more towards a titrate to migrate or titrate to ambulate model where the patient has a goal for their oxygen saturation. In patients with pulmonary hypertension or ILD, IPF, you may look at having that goal as a higher oxygen saturation because of risk of stress on the heart or rapid desaturation. In patients with COPD, we often think that 88% or above is acceptable. Perhaps one of the most important considerations for this population is looking at balance and fall risk, their musculoskeletal status, and any impairment or abnormality, cognitive function, and mood. We would evaluate mood just like we do for the center-based programs using validated tools, pre and post pulmonary rehabilitation, and checking in with them at least midway to determine their symptom level. And I'll show you some validated tools for some of the other assessments in a moment. Home safety is paramount. If you're doing a video-based model, you want to be able to see where the patient plans to exercise. Is it free from cords, oxygen tubing, furniture, throw rugs that they can trip over? With many patients, perhaps all patients, it may be helpful to involve a family member, a caregiver, to work with the patient and to help support them, but also to keep an eye out that they're approaching things in a safe and careful manner. I think a second set of eyes in all medical care is a good thing. Do they have any language or learning barriers? And how can you address that to be sure that they're getting safe, effective care in the home? It would require some clear adaptation, even if this is the appropriate model, or should they go to more of a home PT model? And then finally, and definitely not the least important, is communication with the medical team. I would conference these patients frequently, what the assessment shows, what the approach is going to be, how the intervention is going. You don't want to do this approach in isolation. So this is hot off the press from the European Respiratory Society task force, task force on COVID-19 and rehabilitation. And this came out in the ERS today, and it looks at some of the reasons we might be talking about remote pulmonary rehabilitation in this population, and some considerations for patients that have infection or have had infection with COVID-19. So they remind us that outpatient exercise training improves function and quality of life following critical illness. They talk about the same assessment areas, including pain and fatigue that I just mentioned, and using immediate needs as well as short-term and medium needs. And those are looking at what are the clinical goals and what are the patient's goals. So importantly, we can contribute to the sensible triage of appropriate patients for support after hospital discharge. What we do is unique, and I think we're an important part of this discussion and team. And here you'll see 3 to 4 options for assessment of patients, particularly that are frail or deconditioned, or you want to augment your assessment model. For infectious patients, they recommend low-intensity physical activity and exercises, and describe considering board dyspnea and fatigue level of 3 points or less using a modified Borg scale if there's been no formal exercise assessment. So I think this is a principle that should drive our clinical decision making for this support. Really all patients we see in the home is starting low and going slow. That's how I was taught as a nurse practitioner to prescribe medications for seniors, and the principle holds true for exercise in a setting where you don't have a lot of control over many variables. You want to be very cautious and continually reassess at every session. And you may be best suited to identify who's more appropriate for home or outpatient physical therapy versus pulmonary rehabilitation. We find ourselves explaining to our referring physicians frequently what's the difference and who's appropriate versus who isn't. Some other considerations, we'll talk about exercise in a minute, but some things you should be considering for a framework for safe exercise is that they have a safe surface to hold on to, like a kitchen counter or a very solid piece of furniture, as well as a stable chair with arms and no wheels. Some home options and adjuncts that may help to support and advance exercise might include a rollator, which you see here, which can improve balance and mobility in a certain subset of patients. Floor pedalers may be a good option for the patient. They're available online for well under $100, and elastic bands that you may provide them with, you may mail them to them, or you may give them guidance about what they may select in terms of starting and progression. So exercise prescription. We have validated tools from American College of Sports Medicine, MAACVPR, and ATS, and they all become quite similar in terms of using the FIT methodology of frequency, intensity, time, and type of exercise. None of these prescriptions were designed or developed with home exercise in mind, so they require some adaptation, but the principles continue to be the same, that ongoing a mild level of progression, but with reassessment by you as the professional, you and your team. So, like I said, start low and go slow, with safety being the overriding factor. You want to provide them written instructions so they know what you're telling them to do, and they have resources. And again, consider involving a family member or caregiver if that's possible. So what about resistance? Well, David Verrill, an exercise physiologist in academia in North Carolina, offered us some very good tools and thoughts for when we wrote the exercise chapter of the AACVPR 5th edition of the Pulmonary Rehabilitation Guidelines. So he had some ideas which I've included here. A couple things I'd like to emphasize. Definitely a stable chair is required, and you have to supervise them during these exercises. We can easily give feedback when we're seeing the patient in person. I think it's much more important when they're in the home, because they're not getting quite as much coaching and they may be uncertain. So this is from the platform that's used in Canada by John Bourbeau and his colleagues. And I encourage you to visit the website and sign up for it. It's a very well developed program for remote exercise in pulmonary rehab context. It includes many aspects of exercise that many patients will find helpful. You probably know that John Bourbeau is the father and the world expert of behavior change and self-management in pulmonary rehabilitation. So he really changed our focus from us training patients to us helping patients to gradually improve their habits and their behavior and their exercise routine based on what their goals are versus what our goals are. They include a post-program evaluation, follow-up, and some long-term healthy lifestyle considerations as well. Another very well-developed tool is livebetter.org, which was developed by the Galicki Family Foundation out of Connecticut, along with the American Thoracic Society. So this is a resource for patients to see what pulmonary rehabilitation is and its benefits. It has a very nice U.S. program, pulmonary rehab directory, as does the AACVPR. There's criteria for selecting a pulmonary rehabilitation program and frequently asked questions. Other resources, this is a resource from the British Thoracic Society that talks about many areas related to pulmonary medicine and care in the context of COVID-19, including pulmonary rehabilitation, provided by Claire Nolan out of the UK. Also, Dick Sawalik, our colleague in Connecticut, has used Lyft for his patients once they graduate, and then you'll see the URL here. And I've looked at it, and I thought it was well put together. So I'll talk a little bit more about that in a minute. I definitely want to thank Claire Nolan, Rich Casaberry, Linda Nietzsche, Dick Sawalik, Grace Ann Dorney-Koppel, and most importantly, Ann Holland and Judy Korn for taking this on and being so helpful and careful about making resources available for us quickly. And then up in the right-hand corner, you'll see a guideline for pulmonary rehabilitation from Australia and New Zealand, also a wonderful tool for better understanding pulmonary rehabilitation in various settings. Okay, video visits. Well, this was something that I'm, in retrospect, glad I was forced into, but it's not like flipping a switch. So you would need to work with your IT department and administration. You and your staff would need to get training on the platform and app you choose. We use Zoom. I'd say it's great about 90% of the time, and about 10% of the time it's real problem-solving challenge, and you can imagine it's going to be more so for patients. So patients need, I think, a fair amount of support with these approaches to gain confidence and know that they have a lot to gain. It's just getting there. So I think that's something that we need to be helpful with. So working with your team, you have to choose a platform that's HIPAA compliant, and your IT department should be able to help you with that. Do not neglect your daily notes. You may think, well, this isn't being charged for, so I don't need to worry about it. You should, because you're a clinician. Many of us are licensed, and you're providing care to a patient. You want to really paint a picture of exactly what you're doing, what the outcome was, what the plan is for the next visit. If you're involved, you want somebody to be able to jump in and know exactly what's been going on. This is a draft video visit example from an electronic medical record. This is an adaptation of what UCSF uses. We don't promote it, but it's just what we use. You do have to get permission from the patient before you start setting up this type of model. And we fortunately have admin staff that help by sending a link to the patient to get them on Zoom and with some basic instructions. So this slide is an example of documentation. It's a smart phrase that my colleague Julia Rigler developed using an Epic platform as a format for documenting what the assessment was and what the intervention was and what the plan is. Like center-based pulmonary rehabilitation, but even more importantly, patients need to know when to stop exercise and seek help. This was from a manuscript that a group of us from UCSF wrote for the Journal of Cardiopulmonary Rehab, and this basically is common sense. It's in the guidelines, but you really want to tailor it to what is critical in the home setting. So the patient has some guidelines of what to do if they become symptomatic. Proceed with caution. So there's the good, the bad, and the ugly. And what I'm talking about are remote models for pulmonary rehabilitation that have been developed by clinicians, some of them by not industry, but groups that have developed more of a commercial model. And some of them are very nicely developed. Some of them have nuances that are quite good and some nuances that are a little bit less good. Some are absolutely not pulmonary rehab at all. So you have to really be careful. And I would scrutinize and vet anything that you're going to suggest to a patient. I've reviewed probably 5 models, and they absolutely run the spectrum. I would talk to your medical director and staff about this approach, and then finally, carefully screen your patients for remote pulmonary rehabilitation appropriateness. A few final thoughts from me. I want to talk about boundaries. I worked in visiting nurses in hospice in San Francisco for 8 years, and I learned a lot about boundaries. When you enter a patient's home, it's sometimes tempting to think, wow, they're so nice, and that reminds me of my mother, and that poor patient is alone. And try to be careful that we're professionals, and if you develop a friendship with a patient, the patient may not always understand the barriers of what you can and can't do for them. So think about that, and think about the things you're really good at. The things you're quite good at are being a pulmonary rehabilitation clinician. Collaboration is really key. I don't know about you, but when I first started working in pulmonary rehabilitation, I reached out to local colleagues, Lana Hilling and Gina Thomas, who were significantly helpful to me. And this is an opportunity to feel like you're not isolated. So talk to your colleagues, your state society members, look for guidance and help and support. Try to stay on top of valid information and updates, but try not to get overwhelmed. So it's a little bit of a balance, but it's important. I want to emphasize self-care. This is a very difficult time for everyone. If you didn't have some level of anxiety, I think you probably don't have any nerve endings. But we all have to pretty much think about this the way we tell our patients to think about it. That fitness, nutritious diet, stress management, managing the dose of information is important to get off the wagon, get back on quickly. We as pulmonary rehabilitation clinicians offer an informed team approach where we are in many ways with our team the most qualified to form this new model. So we're starting at the beginning in the US in many ways, but I think that over time we'll learn and we will strengthen this model. I'm going to turn it over to Julia Rigler. Thank you for your time, and please work with AACVPR for any questions or help that you need.
Wonderful. I'd like to take a moment to explain and describe how we've been doing our remote pulmonary rehab exercise sessions. First of all, we are using Zoom as the platform to provide these sessions, and I understand that there may be other platforms such as WebEx that people are using. However, as Chris mentioned, it is very important to make sure that however you are providing this experience, that it be HIPAA compliant. So one of the things we want to do first is we want to ascertain that the patients are ready and willing to participate in this type of pulmonary rehab. If they are, the team or you can send a link, a Zoom link to the patient that describes how to access Zoom. In addition to that, you may want to send a message about what the patient will need to do to prepare for this experience. For example, they should be able to set up and secure their space, their equipment, and their self. So, as Chris mentioned, the room that they are in should be clear of obstacles. They should have the equipment that you have decided would be appropriate for them, such as, of course, the chair, maybe some light dumbbells, and if possible, a resistance or TheraBand. And in addition to that, if a patient has feelings of apprehension or is not ready to exercise, then in terms of preparing themselves, well, they're not prepared. So when you're actually doing the Zoom visit with the patient, sometimes it can be difficult for them to start the video or the sound. The platforms have icons on the bottom, and you can direct the patient to those icons. For example, with chat, you can type in a message to the patient and they can respond if there is no sound. I would recommend that you have a telephone nearby as well. Recently, one of my patients could not get the sound to work, so we were on speakerphone while we were on video with Zoom. So far, we have 7 patients that are actively engaged in remote pulmonary rehab exercise sessions. And there are definitely some differences between doing our usual center-based approach and doing this remotely. Many pulmonary rehab programs have a lot of aerobic exercise equipment that they can use with their patients, as well as a variety of types of resistance equipment. In this situation, I have not encountered any patient so far that has a treadmill or an exercise bike. So in order to get the aerobic component of the exercise program, we're going to need to find ways of doing continuous movement with these patients. So what that means as the provider of pulmonary rehab is that you will need to do a very good job of coaching and cueing the movement. What I've found helpful is to cue the patient a few beats ahead of making a directional or movement change. So what that means is that we don't want to all of a sudden launch into a new movement without prepping the patient in advance. In traditional setting, we're holding space for the patients to do exercise on equipment, and we are not necessarily doing that exercise with them. They're on the treadmill, we're standing by assessing them. In the remote visit, we're actually doing the movement with the patients, or at least starting a segment of movement with the patient and then observing how they're doing with that movement. And one last thing about the overall session is that you may decide to use music with the patients as a way of almost like a metronome counting and of pacing the session. If you do use music, I would choose music that is slow in tempo and fairly neutral without too many interfering lyrics. So getting on to the actual session, as Chris mentioned, there's an assessment that we start off with containing both objective and subjective measurements. So as you can see from the slides, I came up with a little cheat sheet for me to make sure I'm including all the components of the visit session. So we do an initial check-in. As usual, we talk about pain, if the patient is having any pain, what level on a scale from 0 to 10, and have they taken any medication or done any other type of intervention for that pain. So I had an experience this morning where a patient who has a lot of orthopedic issues, she's having an increase in knee pain today. So I decided not to focus very much on standing exercise and instead do most of the exercise session seated. From there, we want to talk about, have there been any medication changes? And I think very importantly to discuss Are they even keeping up with their regular routine of medication? I think that because lifestyle can be so disrupted now, things like brushing one's hair or drinking 8 glasses of water a day or whatever those routines might be, may find themselves a little bit disrupted. And along with that, there could be a forgetfulness around taking regular medications. So we want to check in with our patients and make sure that they are taking medications, especially inhalers. Now we want to talk about, has there been a change in their cough experience, any change in consistency or amount of secretions? And also, as we've been talking about, it is really important for patients to be able to assess their oxygen levels. So far, we've had some patients who don't have pulse oximeters, but we are encouraging everybody to obtain them, along with coaching them on the appropriate use of their pulse oximeter. So we want to get their oxygen level both before the session and at some point during the session. We want to make a note of what oxygen level, what FiO2 they're using, their heart rate, and their dyspnea level, both at rest and at some point during exercise. In addition to that, if the patient has blood glucose issues and they have a glucometer, you may want to check in with them about their blood sugar levels. If they have a blood pressure monitor, that might be something else, as well as a scale. If your patient has heart failure, that might be a part of their regular assessment. Moving on to the actual exercise session, I like to start off with some very gentle movement, pacing that movement with some breathing exercises. So we might just start off by reviewing pursed lip breathing, then going on to doing some movement with breathing, for example, lifting the arms overhead on the in-breath and lowering the arms on exhalation. From there, we can go into either sitting or standing exercises. So after a few minutes of warm-up, we may want to pick up the pace, do arm reaches, little punches, stirring the pot, whatever it is that you might usually do aerobically as a group without treadmills and bikes and arm ergometers. You can do these things with your patient and keep an eye on whether they're able to keep up, and also those indications that the patient may not be keeping up very well and may have an elevated level of shortness of breath. So that would be, for example, accessory muscle use. In the standing exercises, because we're doing these movements with the patient, you may want to think about in advance what you're going to be doing. So one of the things that I do is I do a movement matrix from the Gray Institute Applied Functional Science program, where we're moving in a sagittal plane and a frontal plane. If the patient is an advanced exerciser, we can also do things in a transverse plane and combine these planes of movement along with drivers such as where we look with the eyes or what we're doing with the arms. Included in the exercise session, we are also going to be doing resistance exercises with equipment such as dumbbells and resistance bands, as well as body weight exercises. And I found that what works really well is to alternate a few minutes of aerobic exercise with a few minutes of either TheraBand or dumbbells. If the patient is appropriate for standing exercises, we may want to do things like hip flexion, knee extension, hip abduction, and marching in place, things like this. We could also work with wall push-ups, but again, you're going to need to look at the space that they have and make sure that they've got a place that is going to be safe for them to be doing these wall push-ups. And finally, we can do mobility, both dynamic and static stretching with the patients, both as a warm-up and as a cool-down as a part of the exercise session. I like doing the breathing exercises with the patients as we begin the exercise session and also as a final cool down. I think that this time has been especially stressful for our pulmonary patients, and it's a good idea to check in with them and see how they're doing emotionally, mentally. A few of the patients have told me that they are feeling very anxious, so I would recommend that they check out apps like Headspace for doing relaxation and meditation. And we can also remind them that doing a few minutes of very slow pursed-lip breathing exercise can be also very relaxing. After the exercise session, you may want to send a note to the patients reminding them of suggestions that you've made about their home exercise program. You may only be doing your remote exercise sessions once or twice a week, and it is important for these patients to be exercising maybe 4 or 5 days a week if possible, so you can make recommendations that are specific to each patient about what they could be doing at home. If some patients have activity trackers, they can certainly use those, and rather than recommending something like 10,000 steps a day, which is actually hard to achieve for many people, you may want to find a baseline. What is the patient currently doing, and how can you increase their step count every day? Again, with exercise programming in any population, it is important to understand when to progress the exercise and when to regress the exercise. If you get the feeling that a patient is doing really well with the amount of weight or resistance, the sets or repetitions, you can increase. And I think that's pretty much it for all I have to say about doing a remote pulmonary exercise session. Thank you very much.